Okay, first of all, I would like to thank the organizers for having invited me. It's a great honor and also a great pleasure to be here. So my talk this afternoon is about ovarian cysts in the first trimester of pregnancy. How common are they? What is their histology? How often do they cause complications during pregnancy? And how should we treat them? There are two prospective studies that have tried to answer these questions, and both these studies were performed in London. One study was conducted at King's College Hospital, and that study was published by Jasbeck and co-workers in 2007. This study includes 2,925 women undergoing a nucleotranslucency scan at 11 to 14 weeks. The other study was performed at St. George's Hospital and was published by Kondus and co-workers in 2004. That study includes 3,000 women attending an early pregnancy unit at 6 to 14 gestational weeks. So let us look into the details of the study performed at King's College Hospital first. This study includes 2,925 women undergoing a nucleotranslucency scan, and all these women had their ovaries scanned transabdominally, actively searching for adnexal lesions. Simple cysts smaller than 5 centimeters in diameter were not followed up. What is a simple cyst? It is a unilocular cyst with smooth walls with anechoic cyst fluid. Simple cysts 5 centimeters or larger and all other types of adnexal masses detected at the nucleotranslucency scan were followed up with ultrasound throughout the pregnancy until 6 to 8 weeks after the pregnancy had been completed. 14% of the 2,925 women had a simple cyst smaller than 5 centimeters and were not followed up. 8% had a simple cyst 5 centimeter or larger, and 3% had a more complex adnexal lesion. And these 11% of the 2,925 women were followed up with ultrasound throughout the pregnancy and until 6 to 8 weeks postpartum. 85% of the adnexal masses resolved, and most of them resolved during pregnancy, so that in the end, only 50, that is 1.7% of the 2,925 women undergoing a nucleotranslucency scan had a mass that persisted during pregnancy. Only 2 of the 328 women, that is 0.6% of the women who were followed up because of an adnexal mass, needed treatment for the adnexal mass during pregnancy. One 10 centimeter simple cyst was aspirated during pregnancy because it caused pain, and one woman underwent surgery at 20 weeks because a malignancy was suspected at ultrasound examination. However, that mass was not malignant. It was a benign luteoma of pregnancy. The histology is known for 33 of the 50 patients with a persistence mass during pregnancy. One was operated on during pregnancy, the benign luteoma that I just mentioned to you, and the other 32 were operated on after delivery. And all the masses were benign, the most common histological diagnosis being dermoid cyst, endometrioma, tubal disease, and cystadenoma. We have no histology for 17 of the 50 masses, because at the time of writing up the manuscript, these women had not yet been operated on. So now let us look into the details of the second study, the study performed at St. George's Hospital. This study includes 3,000 women attending the early pregnancy unit at 6 to 14 gestational weeks. 43% of these women were asymptomatic. The remaining patients consulted because of pain, bleeding, or both in early pregnancy. All these women underwent a transvaginal scan of their adnexa, actively searching for adnexal pathology. In this study, simple cysts smaller than 2.5 centimeters were not followed up, while simple cysts 2.5 centimeters or larger and all other types of adnexal lesions were followed up with ultrasound throughout pregnancy and until 6 to 8 weeks after the completion of the pregnancy. 6% of these 3,000 women had simple cysts 2.5 centimeters or larger, or more complex cysts, and according to the research protocol, all these women should be followed up throughout their pregnancy with ultrasound. However, some of the women were lost to follow up, so that, in the end, 161 were followed up. 86% of the adnexal lesions resolved, so that, in the end, only 23 of the 3,000 women, that is 0.8%, had an adnexal mass that persisted throughout pregnancy. 6 of the 161 women, that is 4% of those who were followed up, were treated for pain caused by the adnexal mass during pregnancy. Torsion was suspected in 2.5% of the 161 women, but the diagnosis of torsion was not confirmed in any of these cases. However, it is likely that torsion occurred in 1 of the 161 women, that is in 0.6%, because in this woman a necrotic lesion was found at surgery, but surgery was not performed because of pain, but because a malignancy was suspected at ultrasound examination. Histology is available for 17 of the 23 masses that persisted throughout pregnancy. 1 woman had a borderline tumor. 16 of the 17 masses were benign, and the most common histological diagnoses were dermoid cyst, endometrioma, and cystadenoma. At the writing up of this manuscript, 6 patients had not been operated on, and so histology is not known for 6 of the 23 adnexal masses that persisted throughout pregnancy. So if we sum up these 2 studies, we can conclude that adnexal cysts are very common in pregnant women who undergo an ultrasound scan before 14 gestational weeks. But we can also conclude that the vast majority of these cysts resolve, that is, they are presumably functional cysts. We can also conclude that only very rarely do these persisting cysts cause pain during pregnancy, and very rarely do they undergo torsion. And it is also extremely rare for an adnexal lesion detected during pregnancy to be a malignancy. And this is not surprising, because the incidence of ovary cancer in women 15 to 39 years old is only 1 to 8 per 100,000 women and year, the incidence increasing with the age of the woman. And the most common benign pathology in women who have an adnexal mass detected during pregnancy is dermoid cyst, endometrioma, and cystadenoma. Now, quite clearly, the two prospective studies that I have just summarized are clearly the two studies that are most relevant for people who scan women in early pregnancy, because all the data had been collected prospectively and all the women had been followed up in a standardized manner. However, it might be of some interest to compare the results of these two very relevant studies with the results of other studies where data had not been collected in a proper prospective way and where the women had not been followed up in a standardized manner. And there are many such studies. Well, that slide disappeared, but yes, if we sum up these, shall we say, less relevant studies, they all agree. All of them conclude that most masses that are diagnosed during pregnancy do resolve during pregnancy. All agree that invasive malignancy is extremely rare in pregnant women, but that a few women might have a borderline tumor. And all studies agree that the most common histological diagnosis in adnexal masses found in pregnant women are dermoid cyst, cystadenoma, endometrioma, and tubal disease. And all studies recommend conservative management. And all studies conclude that complications are rare even if the adnexal mass persists throughout pregnancy. For example, the reported rates of torsion vary between the studies, between less than 1% up to a maximum of 4%. I just told you that dermoid cysts are very common incidental findings in pregnant women. And we do have data to support that it is safe to manage incidentally detected dermoid cysts, at least if they are smaller than 6 centimeters in diameter. For example, Caspi and co-workers followed 49 women with an ultrasound diagnosis of dermoid cyst no larger than 6 centimeters throughout their pregnancies and deliveries. These 49 women experienced 68 pregnancies and 63 deliveries, and there were no complications attributable to the dermoid cyst in any of these women. Hu and co-workers diagnosed a dermoid cyst with ultrasound in 17 pregnant women and followed them up throughout their pregnancy. And again, there were no complications attributable to the dermoid cyst in any of these pregnancies or deliveries. Unfortunately, Hu and co-workers did not report the size of the dermoid cysts in these 17 women. Now, even though it is extremely rare for us to find an invasive malignancy in a pregnant woman, it is important to be able to discriminate between benign and malignant adnexal masses also in pregnant women, in order not to miss the rare malignancies that do exist. And the ultrasound diagnosis of different types of adnexal masses does not differ between pregnant and non-pregnant women. So, just let us take a quick look at the ultrasound features of different types of adnexal masses. I will teach you a very easy trick that I use when I try to discriminate between benign and malignant adnexal masses. Any irregularity classifies the mass as malignant, while the absence of irregularity classifies it as benign. There is only one exception to this rule, and that is that some multilocular cysts with an innumerable number of cyst locules are indeed mucinous borderline tumors of the gastrointestinal type. This method of subjectively evaluating the grayscale ultrasound image of an adnexal mass is called pattern recognition. And using pattern recognition, we can not only reliably discriminate between benign and malignant adnexal masses, but we can also suggest a specific histological diagnosis. A dermoid cyst is characterized by the presence of a round white ball in a cyst, and this round white ball consists of hair and sebum. A dermoid cyst may also contain bright, thick spots and thick white lines corresponding to hair suspended in an oily fluid, and most dermoid cysts are characterized by shadowing. An endometrioma is a thick-walled cyst containing homogeneously echogenic material corresponding to the chocolate sauce-like contents of endometriomas. A hemorrhagic corpus luteum cyst is characterized by its spider web-like contents or by the presence of bizarre blood clots. A hydrosalpinx is a sausage-shaped structure characterized by the protrusion of mucosal folds into its lumen. And a para-ovarian cyst is located clearly separately from a normal ovaries. And the most typical feature of a peritoneal cyst is the presence of an ovary that may be more or less distorted and suspended amongst adhesions, either, as in this case here, in the periphery of the cyst or in the central part of the cyst. So how good is pattern recognition? How good is it for discrimination between benign and malignant adnexal masses? In a series of 309 consecutive women with an adnexal mass, it was possible for me, using the extremely simple rules of thumb that I just described to you. Any irregularity classifies the mass as malignant, while the absence of irregularity classifies it as benign. To discriminate between benign and malignant tumors with a sensitivity of 85% and a specificity of 94%. This corresponds to a positive likelihood ratio of 14 and a negative likelihood ratio of 0.16. Now, many of you probably know that an excellent diagnostic test has a positive likelihood ratio above 10 and at the same time a negative likelihood ratio less than 0.1. So you can see that my simple rules of thumb did not achieve the diagnostic performance of an excellent test, but they came very, very close to it. How good is pattern recognition for making a specific diagnosis in an adnexal mass? This table shows the results from my hospital in 1996 to 1997. And if you look at the positive and negative likelihood ratios, you can see that pattern recognition could make a virtually conclusive diagnosis of hydrosalpinx, peritoneal cyst, paraovarian cyst, endometrioma, and dermoid cyst. Now, if we can achieve such excellent results just by looking at the grayscale ultrasound image, do we need Doppler at all? Well, if you want to use Doppler, you should not use pulsatility index and resistance index. It has been shown in numerous studies that PI values and RI values overlap too much between benign and malignant tumors for them to be clinically useful. Instead, you could measure blood flow velocity in tumor vessels, but the best method to use and the simplest method to use is to estimate the color content of the tumor scan. Malignant tumors are characterized by high color content, and benign tumors are characterized by low color content. But the crucial question is, does Doppler add anything to grayscale imaging? I think that most of you can see that the tumor here to the left on the screen is malignant because it has irregular borders and irregular internal echogenicity. And I think that most of you can see that the tumor to the right must be benign because it has smooth borders and regular internal echogenicity. So what happens if we switch on the Doppler? Well, if the Doppler findings confirm what we thought we already knew on the basis of our grayscale ultrasound findings, that is, we find high color content in the tumor that we suspected to be malignant, and we find low color content in the tumor that we suspected to be benign, then our diagnostic confidence will increase. But what if it is the other way around? We find low color content in the tumor that we suspected to be malignant, and we find high color content in the tumor that we suspected to be benign. Now our diagnostic confidence will decrease because we will not know what to believe. Should we rely on our grayscale ultrasound findings, or should we rely on our Doppler ultrasound findings? I will tell you what I do in this situation. I virtually always rely on my grayscale ultrasound findings. It can happen, but it happens very rarely that I change my diagnosis because of surprising Doppler ultrasound findings. And I have been able to show in one of my own studies that adding subjective evaluation of Doppler ultrasound findings to subjective evaluation of grayscale ultrasound findings did not improve the diagnostic performance with regard to discrimination between benign and malignant adnexal masses, but it increased the confidence with which a correct diagnosis was made in 6% of all tumors. However, in the IOTA studies, comprising 3,511 patients with an adnexal mass, subjective evaluation of both grayscale and Doppler ultrasound findings achieved excellent diagnostic performance with regard to discrimination between benign and malignant adnexal masses. The sensitivity was 90% and the specificity 94%, and this corresponds to a positive likelihood ratio of 15 and a negative likelihood ratio of 0.11, which means that subjective evaluation of both grayscale and Doppler ultrasound findings could make a virtually conclusive diagnosis of benignity or malignancy. But pattern recognition requires experience, and the results of all the studies that in all the studies that I have reported to you today, the scans were performed by very experienced ultrasound examiners. But does pattern recognition work in the hands of less experienced examiners? This table shows you that pattern recognition works quite well also in the hands of less experienced ultrasound examiners. In this study, ultrasound examiners with various levels of experience were presented with representative ultrasound images of adnexal masses, and they also had access to some clinical information. And these observers were asked to classify the adnexal masses as benign or malignant on the basis of the ultrasound images and the limited clinical information that they had access to. And then their classification was compared with the true histology of the adnexal masses. Now, as you can see here, not very surprisingly, the most experienced examiners, examiner A and B, who had performed 5,000 gynecological scans and 15,000 gynecological scans, achieved the best sensitivity and specificity. But the less experienced examiners performed quite well too. For example, examiner C, who had performed only about 1,000 gynecological scans, achieved a sensitivity of 82% and a specificity of 92%. And the least experienced examiner, who had performed only 300 gynae scans, achieved a sensitivity of 87% and a specificity of 81%. And this is not too bad. So pattern recognition seems to work quite well also in the hands of examiners with limited experience. To conclude, routine scanning of the ovaries in pregnant women is unlikely to be of any benefit. It may cause harm because it causes unnecessary maternal anxiety, and it may result in unnecessary surgical interventions. If an adnexal lesion with benign ultrasound morphology is detected in a pregnant woman, this woman should be offered a follow-up scan 6 to 8 weeks after the pregnancy has been completed. And pattern recognition is a good method for discriminating between benign and malignant adnexal masses, and it is also a good method to provide a specific diagnosis in a benign mass. Thank you very much for your attention.
Thank you.